Okay, everyone, this is about managing asthma and anaphylaxis in extremis, but we're going to start with some anaphylaxis basics and see how we go. The first thing I just wanted to talk to you guys about is well-being, and this is a fairly emotional talk. It's emotional for me to deliver. I tend to mention some emotional things, but I want you to take away the message rather than the emotion. Hopefully the emotion strengthens the message, but I really do want the focus to be on the medical learning as well as the story. The thing is that we all want to do the best when we turn up to work, and nobody wants to do the wrong thing, and we're all trying to do as well as we can. Sometimes things do go wrong, and I think we need to be able to learn from that in a really constructive way, and so that's part of what this talk is about. It's also, talking about wellbeing, it's also a little bit about what gives you wellbeing in the workplace, and for me that's really about being good at my job. If I'm having a really busy day at work and there's ambulance queued out the door, I feel okay if I can do a good job. The other thing that helps wellbeing is having some role models and people around you that can support you and that you can look up to. So that's both having your colleagues that you connect with, but also really finding people who inspire you, who you look up to, and who you want to be like. And sometimes that's not just one person, it's a mixture. Take the good bits of the people that you like and leave the bad bits behind. All right, so having said all of that, let's crack on and remember, take as much away as you can from the medical teaching. Okay, anaphylaxis fatalities. We're going to just talk some epidemiology. If you die from anaphylaxis and you're allergic to food, it's almost always young people, and it's almost always with someone with asthma, and it's usually from bronchospasm that they die. Venom anaphylaxis fatalities are mostly middle-aged and often out in the bush, remote from medical care. Medication-triggered fatalities, they are, they're often older people with comorbidities, but that's not to say that you can't die any of those ways and that you fit one of those cohorts. And for example, there in Sydney at Prince of Wales Hospital, there was a coroner's report delivered a few months ago that outlines how a 20-year-old with appendicitis died from anaphylaxis in recovery to Zagamedex, which he received intravenously. He had a history of asthma, not bad asthma, but he died from bronchospasm. So that was medication related. Again, asthma was the important history as a young person dying from anaphylaxis. So we're going to just go to part one now. So part one is about recognising anaphylaxis and just the importance of that. It's just as important to diagnose mild acute allergies as it is to recognise anaphylaxis. When we talk about anaphylaxis, we call it anaphylaxis when there's wheezing or blood pressure problems or airway problems. Then we call it anaphylaxis, but actually it's a spectrum. From type 1 hypersensitivity might be mild, and I'm going to give you an example of Max. And as you know, Max is my 15-year-old boy, and as many of you know, he died from anaphylaxis. And we're going to get to Max's story in a little while, but Max's first reaction was mild. He was a toddler sitting in his high chair, eating some peanut butter, and he wanted to scratch his face off. So there was a trigger, there was an acute reaction, but it was a mild reaction. It was skin symptoms. So just because he had a number of mild reactions didn't mean that the next reaction and the way that Max actually died when he was 15 years old was from anaphylaxis. It's really important to diagnose those mild reactions because then they get linked into allergy services, they get their EpiPen, they get education, and hopefully avoid tragedy. Sometimes those mild reactions are only on history, so you have to be able to talk to the parents, acknowledge the story, because that may be just as important. So something that we can do better on. Historical features of allergy on patient history are really important as seeing it in front of you. In Australia, we've got a set of accreditation requirements for hospitals. We've adopted some for anaphylaxis, and you can see the list there. We sort of, recognising anaphylaxis is pretty straightforward, so I'm not going to go through that. When they're wheezy, and when their blood pressure problems are, when it's in front of you, it's kind of pretty straightforward. But I just want to draw your attention to the number 2 point, which is the immediate availability of adrenaline. Now, I'm going to just draw a parallel to childcare centres and schools, primary schools and high schools in Australia, where they've completely adopted and done a fantastic job of adopting action plans, educating teachers, updating education, practicing their EpiPens, and making sure the whole school is aware and can respond to an anaphylaxis emergency. So if you're in a childcare centre, there's an action plan on the wall. The childcare centre staff have got the EpiPen, and if there's a reaction, they'll get it straight away. Now, I'm not sure the same can be said at busy emergency department front doors. It takes time to get adrenaline. Some of us don't stock EpiPens at the front door. It's really important for us to be as good, provide as good a care in an emergency department as can happen in a school and a childcare centre and a high school. It's important. Intramuscular adrenaline does not need cardiac monitoring. It should be a triage medication, and I encourage you all to look at what happens in your own shop, in your own emergency department, and say, right, well, how are we going to get immediate adrenaline at the front door? If they're going straight through to resus, that's great, but what if they're not and it's full and you want to give some adrenaline? Like, you need to have a mechanism for that, and the nurses need to be engaged and be empowered to facilitate that, because they should be able to. So that's number one. All right. Just in terms of time frame and diagnosing acute allergy, there's a trigger and exposure, and then it's 30 minutes. It happens in 15, 20, a very short time. It's usually pretty obvious. There are unusual cases where the exposure might not be for some time. There's some delayed absorption, and it might be up to 4 hours, but that's uncommon. Usually. So some of them you need to scratch your heads and think about, because you're not sure what happened. Was the exposure some hours ago or not? But most of the time, trigger, exposure, some acute symptoms within a half an hour. Okay, so that's a good thing to take home. We're not talking about viral urticaria here, where the kid's got some child has got a viral urticaria that's been going for a couple of days. That's not acute allergy. So acute allergy is exposure, reaction, and it might be mild or it might be severe. There's some diagnostic criteria internationally for anaphylaxis. These have been around for a long time. I think the only missing, this is when we call it anaphylaxis, when the acute allergy is severe enough to call it anaphylaxis. These are the criteria. Now, in terms of the number 3, the only thing that's really missing there is now I think most jurisdictions would include, after known allergen exposure, if there was evidence of bronchospasm alone, we would add that to number 3, which is if you get exposed and there's low blood pressure, we call that anaphylaxis. If it's just blood pressure in isolation, the same thing applies for bronchospasm. But use your clinical judgment. I'm giving you this busy slide, which is kind of full of words, but it's really just a grading system for acute allergy. This is a Delphi study published in the States in 21. It's really good. I like the concept, and I think it demonstrates how far we've got to go in emergency medicine in talking about anaphylaxis in a consistent and sophisticated way. We call anaphylaxis, acute allergy anaphylaxis, when there's breathing, blood pressure or airway problems. That's great, we call that anaphylaxis. But just remember, as we were talking before, it's a spectrum. So the skin symptoms we call mild, but it's still part of that spectrum of type 1 hypersensitivity acute allergy. So this slide shows you that there's different grades, mild, moderate, from 1 to 5, 1 being mild, 5 being, dead or close to arresting. And I think that's really useful, and I think we could adopt a much better way of talking about it in emergency departments. I think at handover, I think this young person has had acute allergy, but it's mild. I'm going to refer them on. It was grade 2, as opposed to this one had acute allergy, met anaphylaxis criteria, etc., etc. So we need to be more sophisticated. Anaphylaxis is really becoming a bigger problem just in the last 20, 30 years. So, the first EpiPens were only around in the late 80s in Australia, probably earlier in the US. Hello to people in the US. In Australia, we use these action plans. I'm not going to go through them, but we expect everyone to go home with an action plan. They're freely available on the ASCIA website. I'm just showing you this slide again, really to hammer home the point that it's a spectrum of disease. So from mild to moderate. So I've just cropped it down from one of their other slides in this paper, and I'm just drawing your attention to the purple box on the left with an arrow that shows that there's acute allergy that's mild and acute allergy that's life-threatening. So we're skipping part 2 to go to part 3. Part 3 has only got one slide. Here it is. It's organising follow-up. Okay, so the patient has recovered from their acute allergy. You've treated their anaphylaxis. You've done a great job. Fantastic. The majority get 1 dose of adrenaline, maybe 2. They go to short stay or for some observation for 4 hours. That's what we do at our place, and then they go home. But when they go home, it's very important. You need to discuss the allergen and identify it. You need to tell them how to avoid it. Sometimes that's easy, like drugs. Sometimes it's hard, like food. They need an EpiPen script and training. They need an action plan, and they need a referral to an allergist. In Victoria, in Australia, we have a mandatory notification system which is all anaphylaxis, not just food, and that's related to making sure it really helps get some data about what further changes need to be made from a public health point of view. So that's follow-up. It's all straightforward, but it's really important, because if you don't do it, then that mild reaction who doesn't get appropriate follow-up then is left exposed and gets mixed messages. So it's really important. That's part 3 done. So now we're going to get to the main part, which is part 2, and that's actually treating anaphylaxis. Treating anaphylaxis is a core specialist emergency medicine skill. This is just like we expect surgeons to be good at operations and not cut the wrong thing while they're doing the operation. We expect emergency specialists to be experts at resuscitating someone with anaphylaxis. I'm going to show you a video of James Sindos when he was 16, and I just want to show you how good he is at playing the piano. Here we go. James died from anaphylaxis, and the reason why I'm showing you that video, he was 16 when he played that. He died when he was 17, and the reason I'm showing you that video is because anaphylaxis happens in young, healthy, otherwise healthy people. Yes, he might have some past history of asthma, but he's otherwise well. He's got another 80 years to live, and what we're talking about today is high yield in terms of interventions to save somebody's life and let them live happily and healthily. So that was James, incredible piano player. If you get through someone through anaphylaxis, he'd be happily playing the piano again. But unfortunately, he died, and I'll show you what happened to James actually. This is James's family. Harry and Vanetta, his parents. I spend a lot of time now with these guys. He's got 3 older sisters. They're all beautiful, and they miss James dearly. That's on their trip to Greece. They're just another family in Melbourne living with a tragedy. So this is what happened to James. So he was 17 years old. He was allergic to cashews. He just finished the school play, Mamma Mia. He's in year 12. He's about to finish school. He ordered a sandwich from a vegan restaurant that had cheese sauce. Now, cheese sauce in a vegan restaurant means cashews, but as a teenager, you don't know that. It said cheese sauce. In the fine print, it said something about cashews, but he ordered it, he ate some, and he developed acute allergy. At the beginning, it was mild. He had some skin symptoms, some tummy, some abdominal pain, felt a bit itchy in the throat. They called the paramedics. The paramedics gave him 2 doses of adrenaline, but he didn't actually really meet the criteria for anaphylaxis in that sort of more severe, acute allergy spectrum. But as he was being triaged at a metropolitan Melbourne emergency department, he became wheezy. And the paramedics alerted the triage staff and the bedside nurse to the fact that there were some new symptoms, but he got put in a single room. And by the time he gets to the single room and he's being triaged, he's got 19 minutes left to live. The first thing that they do is, because James is trying to use his puffer, is to get him a spacer and give him Ventolin. So it takes some time to find the spacer, but they put an IV cannula in. That's great, but he doesn't get any IM adrenaline really until 4 minutes before he arrests. There's some time that goes past. During that time, he starts to get more and more short of breath, and he actually starts asking for help. He says, I can't breathe, I'm going to die, and says that multiple times, and medical staff around him say, James, your breathing looks fine to me. 4 minutes before he stops breathing, he gets IM adrenaline. Now, this is my question to you. How long does it take? I want you to think in your brain, how long does it take IM adrenaline to get to peak effect? Just have a think of a number. What do you think? The answer is 5 to 8 minutes in the literature. So you're not going to get peak effect until 5 minutes, and James has only got 4 minutes left. So that's going to be important when we talk about how we respond to people in extremis, understanding the timeframes. If you give subcutaneous adrenaline, which we stopped doing a long time ago, it takes up to 20 minutes to get maximum effect. So if you accidentally give it subcut and it's not intramuscular, then you actually might not be getting any adrenaline for some time. So you've got to keep in mind that, maybe, if you're not getting an effect, was it subcut? Is it just because, that there's some other risk factors like high dose allergen, or there's some concurrent viral illness or pre-existing asthma? Something's going to make them have a severe reaction. But if you're not getting a reaction, you need to if you're not getting improvement, you need to keep going. All right, so James then stops breathing in his cubicle. He gets moved to resus. He sort of crashes, the hypoxic agitation, and there's a loud bang, and they start CPR in the cubicle. They move him to resus. They start bag valve masking him. They say that feels funny, so they put a laryngeal mask in. That feels a bit better, but we'll come to why that's probably not right. The LMA was thought to be effective, but it's probably not right. He doesn't get real adrenaline until 13 minutes after he's arrested. And he doesn't get intubated until 17 minutes after he arrests. After he gets intubated, he's difficult to ventilate, high pressures. His heartbeat starts to come back. It looks a bit funny, a bit wide. Somebody decides that needs a shock. They give one shock. They're still having tight ventilation, but then they decide to give some amiodarone for unclear reasons. And I highlight this because this is somebody trying to extrapolate a VF algorithm to a completely inappropriate situation. He gets a dose of amiodarone and immediately becomes asystolic on the end of the push. There was no indication for amiodarone. In fact, it's contraindicated. And then he gets another dose. And he eventually goes on to ECMO, but he becomes brain dead and dies 24 hours later after withdrawal of treatment. So this happened in a metropolitan emergency department in Melbourne. Melbourne's a city of 4 or 5 million, 4 million people. All right, so we're just going to quickly go through the nuts and bolts of consensus anaphylaxis management. It's pretty similar all over the world, except we're not calling it epinephrine, we're calling it adrenaline. And what we do here is we give 0.5 milligram, so we're just going to talk adult doses, or 10 mics per kilo. We give it every 5 minutes because maximum effective 5 minutes. If we've still got symptoms, we need some more. So that makes sense. That's why it's every 5 minutes. That's good. If we need more than 2 doses, we start an IV adrenaline infusion. We supplement things. If they've got wheeze, we supplement it with bronchodilators. If they've got low blood pressure, we supplement it with the adrenaline infusion. Sometimes we might need noradrenaline, vasopressin. We're happy to escalate to whatever we need to keep our blood pressure up. We give some fluid boluses. And we might do some nebulized adrenaline for some airway symptoms for what that's worth. But the parenteral adrenaline, the IM adrenaline will be better. All right, so that's what we do. Now, we're going to come to the IV adrenaline bolus in a second, and I've got the adrenaline tachometer up in that corner there. Now, the adrenaline tachometer means that sometimes we just need 1 dose, or some patients, acute allergy, they don't need anything, and they just get observed, go to short stay, go home with the follow-up. Sometimes I need 1 dose, sometimes 2 doses. More than 2 doses, we're getting down to the 10%, and to need IV adrenaline, we're getting down to really small percent. So, it depends which cohort you read in the literature. Arrests are rare, but important. So, this is the nuts and bolts of it. For the wheeze and asthma component of anaphylaxis, we use parenteral adrenaline, IV or IM, plus the bronchodilators, plus in Australia, in Victoria, we would give an IV for anyone with asthma now. We're pretty comfortable with that. And we might intubate them. For the airway component of anaphylaxis, it's the same, parenteral adrenaline, plus maybe some nebulized adrenaline for what that's worth, and an early ETT if it's progressing. And for blood pressure, we give the fluids on top of the parenteral adrenaline, but we always start with adrenaline. Now, IM adrenaline is completely safe. There's 20% of people who might get some minor side effects, tachycardia, some tremor, but to cause any harm from IM adrenaline is exceedingly rare. Feel comfortable giving it, feel comfortable giving multiple doses. We swung away from IV adrenaline years ago because people were giving too much. We know IM adrenaline is extraordinarily safe, but as critical care specialists, you need to know how to do more than IM adrenaline. Yes. If you want to give IV adrenaline because we need help now, not in 5 minutes' time when the IM adrenaline is kicking in, the dose is 1 microgram per kilogram. This is APLS, which is a paediatric resuscitation course that we often do in Australia. It's elsewhere in the world. But I'm just drawing your attention to the middle row, which is adrenaline IV, and that it's got titrate 1 microgram per kilo with a star on it. And I've put the star up the top, and the star says 1 microgram per kilogram given over 1 minute. The range 30 seconds, push, to 10 minutes. And when something says 30 seconds in a book, that means just, push it in. It's a bolus. So if you need help right now, then you need to have the adrenaline IV ampule drawn up in your hands. And I'm going to put a video up of how to draw up IV adrenaline, because it's a core technical skill for doctors to be able to go get an ampule of adrenaline and make it into 1 milligram in 10 mils, or another dilution of 10 for the smaller people. But you need to know how to do it. Take that home with you, 1 microgram per kilogram as an IV bolus if you're in trouble. Remember, the guidelines are always written in stepwise severity. So it starts, this is what you do with mild cases, moderate, severe, but sometimes you're faced with a patient who's got the severe case. They haven't gone through each stage. They just present on your doorstep blue in the parent's arms, or by ambulance with a GCS of 3. And you need to start at the bottom. So that means going for the IV adrenaline first and then supplementing with an infusion. So speaking of adrenaline infusions, how long does it take to get an adrenaline infusion drawn up in your department? What do you reckon? I've done this talk a few times now, and 10 minutes is the consensus. So, 10 minutes, and then you've got to start the pump, and it's got to get rid of the dead space, and you started at a low dose, and then you need to titrate up. It's a slow process. That's great if they're awake and talking. It's completely inappropriate to wait that time if a patient's in extremis and unconscious. Remember that asthma can decompensate very rapidly. It's inversely, the airway resistance is inversely proportionate to the radius to the power of 4. So small changes in the bronchioles will cause catastrophic changes in resistance, and there'll be sudden deterioration. So just like all, especially young people in paediatrics, they compensate in a linear fashion and eventually just suddenly stop breathing. So you need to intervene before that happens. So if there's severe hypoxia or somebody's begging for help, those are signs of impending arrest, and you need to get some push dose IV adrenaline, NIV if you can, and get ready for the next stage. So we're getting close to the end of this section, but I just want to say what should have happened to James as an emergency specialist myself. Hi James, it looks like you've got some asthma symptoms with your anaphylaxis. Don't worry, we're going to look after you. We're going to give you some IM adrenaline, and we're going to give you some Ventolin. We'll give you 12 puffs, and we'll give you 8 puffs of ipratropium as well. And we're going to move you to an area where we can keep a closer eye on you. And then 5 minutes later, because it takes 5 minutes to deliver 12 puffs of salbutamol and the ipratropium, and this is what I did for an anaphylaxis patient at my shop, a couple of months ago. So and it worked really well. 5 minutes later, they're still wheezy, and our endpoint is saying, well, if they're deteriorating, we need to keep escalating. But if things have stabilised, we can just think about our next move and do things slowly. And if they're getting better, we can back off. So we always have to keep thinking about our endpoint. If improving, we can say, okay, all right, well, we'll just see if that IM adrenaline is going to keep working. But if they're deteriorating, you need to keep escalating. So 5 minutes later, he's still wheezy. James, you're still wheezy. In fact, that really doesn't look like it's done anything. Here's another dose of IM adrenaline, and here's another dose of inhaled bronchodilators. James gets worse. Turns out he's got a cold, he's got asthma. He had a decent dose of cashews. This is a catastrophe. James, it looks like your asthma is getting worse. Let's get some IV adrenaline. Nurses, can you get me 1 in 10,000 adrenaline ampule, and I'll draw that up. And James, I'm going to give 100 micrograms. Can you get the intubation equipment ready? We'll get the adrenaline infusion coming. James, you're going to be okay though. We've got this under control. We could try some NIV if we had time to do that, but we would be totally prepared for him to decompensate and stop breathing, about to intubate him. And that's what should have happened to James. He might have been fine after the first dose of adrenaline if you had have got it early enough. The next section is about arrest algorithms. It's really some important concepts here. So I'm just going to draw some parallels to another scenario in emergency, which is trauma. Traumatic cardiac arrest guidelines have been accepted and have some evidence to say that they actually improve outcomes now, published in the literature. They're widely accepted. We hope that we get a traumatic arrest well before they're asystolic. We hope we get them when they're pulseless or sometime before that, so that we can do a specific set of interventions that are much more effective than CPR and adrenaline. We don't want to do CPR. It's going to interfere with decompressing the chest, giving the blood volume, decompressing the pericardium, putting the tube in. I work at a trauma hospital. That it happens simultaneously, all of those things. In Australia, we use this thing called the 4 H's and 4 T's to think about reversible causes of cardiac arrest. It's not that helpful because hypoxia, that one of the H's is for hypoxia, but it doesn't tell you what to do about hypoxia and asthma. It just says, oh, they're probably arrested from hypoxia. It's not descriptive or prescriptive. So we need to move on and evolve our resuscitation algorithms to be more sophisticated than they are. We've done that with trauma, and we've done it really well, but there's other conditions that would be suited to its own algorithm. Most jurisdictions have resuscitation in special circumstances, but we need to expand that. Just going to make some parallels between VF versus hypoxic arrest. In VF, the blood is not deoxygenated. Your heart suddenly stopped, but your sats were 100 when that happened, if we're talking about the classical scenario. I know there's lots of versions, but the lungs still work. And we can probably, the brain's going to start dying in 4 minutes, But we can extend that time with effective CPR and maybe a couple of breaths every minute and doing some, and the priority is about chest decompressions and defibrillation, as it should be. It's an extraordinarily good algorithm, but only if you've got VF. In hypoxic cardiac arrests, the blood is already completely deoxygenated. That's why the heart bradycardied out and stopped. So we've got deoxygenated blood and the lungs don't work or the airway doesn't work. And so if we do CPR and adrenaline, all we're doing is circulating deoxygenated blood. And we can't extend the time for brain survival unless we fix the lungs or we fix the airway. The approach is ABC. So I don't know what's happening elsewhere in the world, but in Victoria, we've de-emphasised, and I suspect this is elsewhere as well, is that we've de-emphasised early intubation in adult arrest practice. And that's partly because of the success of the VF algorithm. It's great. And it's partly because that's what we learn when we go into our ALS training is that, it's 30 to 2, 30 compressions, 2 breaths and a bag valve mask. And that feels comfortable to us. But sometimes that feels easier than actually trying to do what might be right for the patient. It's clouded by some pre-hospital studies where trauma and cardiac arrest data have variable findings. So we haven't quite got the emphasis right. So, and that especially applies to asthma and anaphylaxis, where it really needs to be an ABC approach, and we're going to go through that now. So why is there a need for a specific asthma and anaphylaxis algorithm? Well, asthma and anaphylaxis are no different to trauma in needing a set of specific interventions which are more effective than CPR and adrenaline. There is no respiratory arrest algorithm out there. So when these guys have a respiratory arrest, we need to intervene with some specific interventions, but lots of protocols just say go to the ALS algorithm, which is not what they need. They need the ABC. But respiratory arrest occurs universally in asthma and anaphylaxis as they arrest and become bradycardic and asystolic. And the teaching of this topic currently lies with decentralised teaching, particularly here in Victoria. It depends on who your teachers are, who your, what the culture is of your emergency department, what sort of case mix you see, because it's not centralised. And so, I know what to do. I teach my trainees what to do for the last 10 years as a director of training in ED, but that's not the same teaching that necessarily gets delivered down the road. It doesn't cater for people under stress. There's nothing there to support them in this situation, and it doesn't cater for the lowest common denominator because some of us need to be better than we are. This is an example of, ongoing anaphylaxis management from Safer Care. It says request further help from critical care, but that's you. You're the critical care specialist. So they're calling you for help, and you know what to do because you're the expert specialist. This is weird. It says cardiac or respiratory arrest, commence CPR. But we shouldn't commence CPR on a respiratory arrest. We should just intubate them. So the next section is about grouping asthma and anaphylaxis together in an arrest algorithm. So we can put them in the same basket. If an anaphylaxis patient presents unconscious or an extremist from food allergy, there's a 90-something% chance that arrest has happened from bronchospasm, according to epidemiology of anaphylaxis deaths. You could safely apply that to any anaphylaxis in any setting. In theatre, the airway and breathing is often controlled, but in the perioperative setting, like that Prince of Wales case, the bronchospasm happened in a fulminant way, and we really could extrapolate, treat asthma as anaphylaxis and anaphylaxis as asthma, and I'll talk a little bit more about that. And when I talk about asthma, I'm not talking about the 99% of asthma that comes in and you give them some bronchodilators and they get better. I'm talking about the people who turn up blue on the doorstep, or have thunderstorm asthma, or just essentially presenting in extremis. Both groups of patients can be managed with the same therapy, which is adrenaline and cardiorespiratory support. You can tailor things as they evolve. Some asthma is actually anaphylaxis, There's a study published in the US in ICU, ventilated ICU patients that had asthma. 4% of them were actually anaphylaxis patients. So if you see an asthma in extremis that you haven't got the history from and they've turned up on your doorstep, it could be anaphylaxis. But you need a clear mental model about what to do before it unfolds, so you can start your time critical response at a brainstem level. All right, and this is, so Max has been providing the photography for this presentation. That's his dog Millie. Now, I've just to demonstrate that anaphylaxis and asthma can be treated in the same way, I've got the Ambulance Victoria guidelines, which are freely publicly available. They show that in AV anaphylaxis, in their clinical practice guideline, there's bolus adrenaline IV and consider intubation. And then if we go down to asthma, down the bottom it says adrenaline IV, at 2 minutely. So it's the same treatment, asthma and anaphylaxis. The other thing that's important when trying to develop or think about arrest algorithms and asthma and anaphylaxis is actually recognising what respiratory arrest looks like. And talking to some of my PICU colleagues, this is the best definition. Unconscious, requiring bag valve mask support in the setting of asthma and anaphylaxis. So if they have that condition and you're actually having to help breathe for them, they've had a respiratory arrest. And you should call it as such. You can use the poo of AVPOO, like the pain or the unresponsive, that it might be an appropriate threshold. But it's important to know that respiratory arrest, it's often accompanied by hypoxic seizures. There might be some, residual respiratory ineffective effort. It might be that they have some residual motor response. All of those things are common, but they've had a respiratory arrest. They're now not breathing effectively and they've become unconscious. And respiratory arrest it will progress to cardiac arrest through bradycardia. So they then become bradycardic and then they become asystolic and that's it. All right, but that's what respiratory arrest looks like. You need to be able to recognise it and not be distracted by any of those things and call it for what it is. This slide will skip, but I'm just trying to explain that there's nothing new here. All of this is just trying to put everything we already know about asthma and anaphylaxis into a structure that would be helpful for us in an emergency. Okay, so this next section is about 10 concepts that will help inform an asthma and anaphylaxis resuscitation algorithm. There's 10 concepts, but I'm going to spend one section on the first. What we're going to do is go through the first concept, but what it's going to lead to, these 10 concepts, is an algorithm that supports you in time-critical situations. And we've called it the AMAX4 algorithm. Now, it doesn't have to be Max, it could be anyone's names. My Max's name's everywhere. You see maximum this or maximum that. I don't really mind if you don't remember what the Max stands for, but what I do care about is you remembering the 4. And really what the algorithm, what this mnemonic is saying is maximum 4 minutes, max 4 minutes. If you remember what the AMAX is for, that's great. It's a really helpful algorithm, and I'll take you through why, but it's about the 4 minutes. Okay, let's get on to the first concept. Concept 1, the time to hypoxic brain injury is 4 minutes. Brain tissue has no oxygen or metabolic stores. Loss of consciousness happens in hypoxic arrest when the PO2 is less than 29, and that corresponds to roughly in the SATs of the 40s. So if your SATs are in the 40s, the brain's going to start to die within 4 minutes. The areas of brain that die first are those with the highest metabolic rate. So that's universally first the hippocampus, followed by the cerebellum and basal ganglia, then the occipital lobes, then other parts of the brain. It is so predictable. So the time to hypoxic brain injury is 4 minutes, but let's just talk about primary and secondary brain injury. So primary brain injury is determined by the time to restoration of oxygen and blood flow. And this is our specialty as emergency specialists at the end of the ambulance ride to intervene at this point. We have all the power to make the biggest difference to somebody's outcome in that first 5 minutes. We spend a lot of time talking about secondary brain injury in critical care. I do some retrieval. We talk about preventing secondary brain injury all the time. There's lots of research in intensive care and post-resuscitation care, millions of dollars. But the outcomes haven't really changed that much in the last 20 years. And when I talk about preventing secondary brain injury, we're talking about targeted temperature management, glycemic control, etc., etc. But the biggest determinant, so yes, secondary brain injury happens, and when you have hypoxic brain injury, that injury continues, and so you get deterioration after the insult. So you sort of think you're going okay, but then the secondary brain injury, you realise that the prognosis is sometimes a little bit worse than it looked at the beginning. But the primary brain injury is where all the money is. Yet, how many millions of dollars do we spend trying to get it right at the front door? How much time do we practice doing emergency tubes? Past 4 minutes, time is brain. Every second counts. Every second becomes tens of thousands of neurons, and that's really important to the person in front of you. And even if we're just talking about changes in personality. So if you get it right, they'll be back to normal. But if you don't get it right, well, then they've got this acquired brain injury. And if you really get it wrong, then they're in a nursing home. And worse still, they become brain dead. So it really is a super time critical condition. And we should be very regimented. And we'll get to the regimented bit in a second. Everyone knows about the Elaine Bromley case. This was a healthcare tragedy. There was 20 minutes of hypoxia during a routine elective operation. The oxygen saturations were 40s in most of that time. Her husband Martin pointed out that practice simulated competence at dealing with emergencies is, he was a pilot, is what the medical industry also needs and should have as a benchmark. Yet the same thing is still happening 20 years later. This is what happened to Elaine Bromley. I don't want you to read it, but all I want you to do is take away that 4 minutes, 4 minutes after the laryngeal mask goes in and she's induced, her sats are 40. So 4 minutes from there, her brain starts to die. And yet it goes on for another 20 minutes before she gets her oxygen back, because they just stop the anaesthetic and let her wake up, and they don't realise that she doesn't wake up in recovery. So Martin's been very kind. We've had some correspondence. We've had I said, Martin, we need a hard stop because this stuff is still happening. And he said, well, sure. Then there's hard stops in aviation. For example, if you're flying a plane and you get to a certain fuel threshold, it doesn't matter what other parameters are happening, you turn around when you get to that fuel threshold. It's a hard stop. And if you're flying a plane, the ground's a pretty hard stop too. So there are some hard stops in aviation, and we need some hard stops to help us in medicine. And we need to make sure that we have triggers for those hard stops. In resuscitation and critical care, we're poor at articulating hard stops, like we say early intubation, or this, because we have this sort of cognitive, you get to adapt things to different situations, but sometimes we just need to be regimented and have a hard stop because that's what our industry requires. Hard decks are important. Max loved Top Gun, so we're going to get to a Top Gun scene in a second. But this would be where the hard deck is, or the hard stop for Elaine, which is there, and so that would have needed a surgical airway at that point. Now, Martin's also very good at pointing out the difference between that you can't separate technical factors from human factors. And so what I mean by that is, if you're really good at intubation and you're comfortable with the surgical airway and you can draw up some adrenaline and push dose adrenaline and you know how to do NIV and you're comfortable with that stuff, then all of the things that conspire against you to, all of to stop you doing the right thing and confuse you, all of those things become less influential because you're comfortable. You go, just intubate them, or I'll intubate them, or I'll do the surgical airway. So if you're comfortable with it, so be good at technical things. It will help you. The human factors that we use are about equipment and identifying hard stops and maybe getting a stopwatch on the resus wall that we don't use in Victoria, but some jurisdictions do. We rehearse mini sims, rehearse it, and we practice things together. These are the ways we reduce human factor errors. But you can't separate them, and Martin's keen to, is good at highlighting that. I'm going to show you another video, all right? So if the sound doesn't work, you can always read the subtitles. So here we go.
The hard deck for this hop was 10,000 feet. You knew it, you broke it. You followed Commander Heatherly below after he lost sight of you and called no joy. Why?
Sir, I had Commander Heatherly in my sights. He saw me move in for the kill. He then proceeded below the hard deck. We weren't below 10,000 for more than a few seconds. I had the shot. There was no danger, so I took it.
You took it. And broke a major rule of engagement. Lieutenant Mitchell, Top Gun rules of engagement exist for your safety and for that of your team. They are not flexible, nor am I. Either obey them or you are history. Is that clear?
Yes, sir.
Dismissed.
So that's a little bit tongue-in-cheek, but also not tongue-in-cheek at all, because we need to be good at what we do and set ourselves standards. And that's having some expectations is important. Okay, the other 9 concepts, and this will be really quick. They're all really super important, but they're all super discrete and totally uncontroversial. Here we go, you ready? Concept number 2. Airway pressures are high in asthma and bronchospasm and anaphylaxis. 50 to 100 centimetres of water, super high. Some case reports up to 120. LMA start leaking at 25 centimetres. It is unknown how long you can bag and mask somebody with these high pressures. The path of least resistance will be to the esophagus. We know in paediatrics we inflate stomachs. It will inevitably fail through hypoxia or through stomach inflation and aspiration, but it will inevitably fail. And we've got 2 cases here that demonstrate that perfectly. An endotracheal tube with an inflated cuff is the only effective method of oxygenating an arrested asthma or anaphylaxis patient, full stop. It's not controversial. I've discussed it with multiple intensivists, colleagues, and I think we all agree that that's the case. Concept number 2. Immediately securing the airway with an endotracheal tube has multiple other benefits. Preventing aspiration is super important. Vomiting is common in anaphylaxis. Any aspiration in a bronchospasm and reactive airways is catastrophic and will make your life miserable in terms of ventilation afterwards. And it's critical to avoid that. That is really important, to avoid aspiration. So unconscious patient with asthma and anaphylaxis, that tube goes in to protect their airway. But if it's anaphylaxis and you don't know what's happening to the airway, because things evolve very quickly, right? And progressive airway edema happens. And what it might be an easy tube at the beginning becomes a hard tube 10 minutes later. Concept 4. The first attempt should be the best attempt. Muscle relaxant should be in the resuscitation trolley of every ED. There should be a video laryngoscope ready to go. And it should be the best intubator in the room. Not the hospital, the best intubator in the room. We don't have time to wait for anaesthetics or intensivists or whatever happens in your place. This is core emergency medicine and it's the best intubator in the room. sedation and waiting for sedation should not delay your intubation. It will come. We'll get the tube in first. We only need 2 drugs, adrenaline and rocuronium, or succinylmethonium if you still use it. But you only need 2 drugs. It takes time to get the sedation or midazolam or ketamine or whatever you use. It takes time. We don't have that time to wait, but it will come in a few minutes. Concept 5, an inability to intubate on the first best attempt becomes a KICO until proven otherwise. Can't intubate, can't oxygenate. That means the surgical airway follows immediately. 1 attempt, then surgical airway. Should happen within 4 minutes. Concept 6, what other cognitive pushes do you need to go and do this heroic thing that actually you're pretty comfortable with because you're an awesome emergency physician? No unconscious patient arrested from asthma and anaphylaxis is going to magically wake up. Now, I know there will be an exception to this room if it's to this rule if it's a straight asthma case and they're still breathing and you give them some adrenaline and bag them up and maybe you can get away with it if it's a little one. With that, there might be an exception, but in the adolescents and the anaphylaxis cases, they're not waking up. This is a hypoxic arrest. Crack on. You can delay things until they have brain damage, but you should. This is your cognitive push to go ahead. You have permission. I'm giving you permission. Concept 7, intubation practice. We need to be practiced at doing emergency intubations. It's just something that we do because that's what we do in our department. We can do an emergency tube. It's no problems. Arresting patients, they're time-critical intubations to avoid catastrophe. There's no checklist. We don't delay the time-critical intervention, and it relies on mini-sims, in-situ sims, pre-practice. There's no formal checklist. In awake patients who are intubating in the emergency department, they're awake. We've got everything to lose here. It's about optimising checklists, doing everything in every way possible to avoid catastrophe when we put them to sleep and give them induction drugs. In a myocarditis patient, cardiomyopathy patient, that might include having ECMO almost plumbed and the wires in on induction. Checklists are good. Now, I've given this talk a few times and some trainees want a t-shirt, and the t-shirt they want is saying on this side, if they are dying, save their life. Go ahead. But if they're awake, don't kill them. I don't know if we'll get those t-shirts made up, but you need to understand that concept. You've got nothing to lose on this side. You're only going to lose by delaying. On this side, you've got everything to lose by not being prepared. Concept 8, pneumothorax rates in positive pressure ventilation patients in ICU are low. Pneumothorax rates are high if there's CPR or arrest involved. If things aren't improving or deteriorating, you really need to think about it, and if things really are going badly, then you decompress. And when I say going badly, I mean like still SATs in the 40s or bradycardia. It's difficult to diagnose on ultrasound and supine chest x-rays in the heat of the moment. So it's something that you need to be considering. Now, concept 9 is extreme ventilation. Now, asthma patients, once you get the tube in, you can't relax like other patients. You've still got a lot of work to do. And that means implementing medical therapy for the bronchospasm, but it also means doing some really awesome ventilation. And so it's going to feel tight. It's going to feel like a brick, but you need to deliver something. So yes, you do have to squeeze that bag hard, but you're only going to deliver small breaths. If you could use a bag, not a ventilator, at the beginning until things are under control, because setting a ventilator to have pips of 100 is really hard. You need to get things under, get a feel for things with a bag and mask first. We don't want a breath stack. You want to make sure they fully expire. If things are really bad and at the beginning, you can do the lateral chest squeeze. So you can deliver the breath, lateral chest squeeze, then give another breath. Certainly that's what I did for Max and it worked. There's multiple case reports of it working. It's another cognitive aid to stop you breath stacking and getting too excited, so that you're pausing between breaths to do something. And so I think it can be useful even if it's just a cognitive aid. And lastly, concept 10 is extramedical therapy. So this is where you've used your 2 emergency drugs and you're asking for all the more drugs to come to help this bronchospasm or this low blood pressure. And for the bronchospasm, that's adrenaline, it's bronchodilators. I would use salbutamol IV as a load, say for an adult 250 micrograms. You could give some ipratropium in the circuit. I wouldn't be scared of magnesium, even though it vasodilates and puts blood pressure down. If I'm on an adrenaline infusion and my blood pressure was under control, I would give the magnesium quite quickly, like over 10 minutes. It's supposed to be over 20. I would use ketamine as my sedation and steroids, of course. With the blood pressure, it's easy. Some fluids, some adrenaline, some noradrenaline, some vasopressin. We just keep escalating until the blood pressure is perfusing. So that's concept 10. So that's it. So if we put all of those concepts together, it ends up in being this a AMAX4 situation. It ends up being a AMAX4 algorithm. And again, the 4 minutes is the crucial point. But it's all based on science from first principles. There's nothing controversial or new here. It's just giving you a structured approach. So just to recap what it is, it's adrenaline, 1 microgram per kilogram as an IV bolus that can be over 30 seconds or every minute, or as things improve, you space it out more while the adrenaline infusion is coming. Usually it takes about 10 minutes for the adrenaline infusion to get drawn up. It involves the muscle relaxant because our first attempt, we're only doing 1 attempt, so the first attempt has to be the best attempt. I appreciate that if someone's asystolic and got no tone, that's fine. You don't need the muscle relaxant, but you're hoping that you do, and you should use it. You have complete permission to use it on arrival if there's IV access. You'll need some intraosseous, you need some pretty rapid IV access. Airway is the ETT, as we discussed, and all the extras and extreme ventilation, but remember it's all about the 4 minutes. So that's a AMAX4. It's actually a really good algorithm. It gives you some structure, and the key is, again, maximum 4 minutes. And just to remind you that the top line is the indication. If unconscious, needing assisted ventilation from asthma or anaphylaxis, then it's a good algorithm. Okay, I'm just going to spend 5 minutes just briefly saying what happened to Max. So Max is 15. This is Max here with his 2 sisters and his mum. This is my family. This is Max's 15th birthday. It was his last birthday. He's fit and well, 15-year-old. He had lifelong asthma, no ICU admissions. He was perfectly well that day. He'd known lifelong allergies to tree nuts and carried his EpiPen everywhere. He was staying with his grandma, as he did once a week for many years. He ate a dish accidentally that contained ground walnuts. So it was a big dose in some apple crumble. His mum was around the corner about to pick him up, and he was 10 minutes drive from the nearest hospital with an ECMO service. He experienced itch, 1 vomit, and developed wheeze. He used his EpiPen himself. He started using his Ventolin. 000 was called at the same time, and it was 13:50 on a Friday. There was no healthcare system stress that day. So this is what happened to Max. And he was in the care of paramedics for 28 minutes before he arrested. When they arrived, his SATs were 100%. He was tachypneic. He could speak in sentences. He could tell them that he had anaphylaxis. They said, "Oh, he looks like you've got asthma, Max." And he said, No, this is anaphylaxis. It's come on too quickly." He gets some intramuscular adrenaline. They call for some backup. They give him a second dose of IM adrenaline. But then, due to a set of circumstances and some sort of staff there was some junior staff involved and some equipment failure. He ended up getting into the ambulance and he effectively arrested just as he was getting his third dose of IM adrenaline, and then he got an IV dose. So he really only got 2 doses of IM adrenaline before he arrested. And his last words were, "I'm going to die." And he said that in a very clear voice. His mum was in the front of the ambulance. There was no altered voice, no airway symptoms. This is what happened when he arrived in the ED. So his GCS was 3. These were the obs, normal blood pressure. SATs were 43%, and there was apparent seizure activity. He had IV access in situ. FASM 1 is the team leader. FASM 2 takes the airway. FASM 2 stated they can ventilate easy, which is obviously unlikely with bag valve mask. And FASM 1 says, "Are you sure?" FASM 2 says yes, and they give midazolam for the hypoxic seizure. So at the same time, I'm leaving my work in uniform, and I ring another FASM, and they said, "Don't worry, there'll be an anaesthetist there." But really, what I wanted them to say is, "Don't worry, there's a good crew of emergency physicians there." This was Max's hard deck, which was on arrival. He got half a milligram of IM adrenaline, and that'll take 5 minutes for maximum effect. And then he gets a very low dose of adrenaline infusions 9 minutes after he arrives. They call it code blue. They don't try to intubate. The anaesthetist comes and decides that the airway might be difficult, so he doesn't have an attempt at intubating. And it wasn't until the intensivist comes along that the first attempt happened 16 minutes after he arrives. Then that was difficult, a dose of rocuronium, and then another attempt. And in between, as the rocuronium, or just before the rocuronium's given, I arrive. It's a chaotic resuscitation room. It's clear to me that Max is unintubated, and that's the problem. And effectively, he was asystolic with a couple of agonal beats. I became the de facto team leader. I directed the surgical airway. The intensive care consultant cut Max's neck, but was on the wrong side, and it was on the head side, and nobody on the feet side to help. So I had to go around and put my finger in Max's neck to put the bougie in, and then I took over ventilation from the anaesthetist. And within 2 minutes, Max's heartbeat came back, as you would expect from an hypoxic arrest, and then his oxygen saturations come up slowly, but he's being plumbed for ECMO at this point, and he goes on to ECMO, and we sort of relax the medical treatment. This is Max and his surgical airway. He's a much better looking boy than that. This is what you look like when you've just been resuscitated. Now, the reason I'm showing you this picture is because I want you to appreciate that there's no blood, there's no depressed skull fracture. Max's arm is not hanging off, that there's no trauma, there's nothing to say that all of the things that cause people to panic in emergency, none of those things are present. Max just silently died. His brain was irreversibly damaged just silently while people tried to do things around him rather than what actually mattered. So I just want you to take home that picture that hypoxic brain injury is silent and there's no cue. You need to be looking for the cues. There's no, it's not dramatic appearing, but at this point Max's brain is irrecoverably damaged. I'm not going to go through these slides. I'll put them up as part of the presentation, looking at Max's airway management. I was the sixth person to manage Max's airway, but there was a laryngoscope and an intubating capable person for the entire duration of Max's arrest, including beforehand. And breathing, was a linear deterioration until he decompensated. It was, he became incontinent and asked for help and was predictably deteriorating until he decompensated and became unconscious. And in terms of circulation, it was never a problem. So I'd just like to share with you what happened to Max. 3 hours later, he had a bronchoscopy which showed significant laryngeal edema. So while he had no airway symptoms when he stopped breathing and became unconscious, the delay in time to intubation meant that laryngeal edema occurred, and presumably that was what was making the airway difficult. His arrest, I want to be clear though, was purely from bronchospasm and the asthma component. He was on ECMO for 4 days, mainly because of aspiration in his right upper lobe. He had a devastating hypoxic brain injury with an autopsy and MRI report that shows those findings that I described earlier in the earlier section. He got transferred to the Children's Hospital. He was off all support on day 7. He just had his trachea in, but he could only poke out his tongue to command. He could move his limbs, but not purposefully. And on day 13, I could actually go outside with Max, and the day before he died with one of the ICU nurses. But then at 7 o'clock, we got a phone call in the morning, and he just suddenly and totally unexpectedly died. We were actually filling out the disability paperwork for him. And that was because of his brain injury that happened. We like to think that was Max's choice. This was the rainbow over Melbourne when we opened our curtains the next day, on our first day without Max. It was taken from a different place by a friend. And this is a much better picture of Max. This is how I want you to remember him. He's a happy boy. He's just been to the Kit Kat factory in Sydney, and he's got his Kit Kats with he went with his sisters. Thanks very much, everyone.